welcome to the latest edition of Infection Control Matters. Today I've got Professor Josh Davis and Dr. Sarah Browning from Hunter New England Health District in New South Wales, and also part of the HMRI, the Hunter Medical Research Institute. Welcome both.
Thanks, Brett.
Hi, Brett. Thanks for having us.
My pleasure. And a conflict here, I work with both Josh and Sarah on a few different things as well. Now, today we're going to be talking about a paper that's just been published in Infection, Disease and Health. It's called Have Gloves and Gowns Had Their Day? And it's an Australian and New Zealand survey about contact precautions for MRSA and VRE. So, Sarah, you led this piece of work. Do you want to just give us a little bit of a background as to why you're interested in this topic of contact precautions?
Sure. Well, I think it's become quite topical in within sort of IPC fields. So there's a lot of conversations happening at the moment as to how we should best be managing our patients who are either colonised or infected with MRSA and VRE. And I think adding to that has been this mounting concerns, I suppose, about climate change and, how hospitals are contributing to increased carbon emissions. And so particularly through the COVID pandemic, there's been growing interest, I suppose, in the amount of PPE that's being used in healthcare. And I think that's contributed somewhat to, people within IPC thinking about the role of gowns and gloves for VRE and MRSA, although I know that, this has been talked about for many years predating COVID. And so it really just stemmed from discussions that we were having within our own department and also with people in other hospitals around Australia as well, recognising this growing interest in answering the question, I suppose, as to whether gowns and gloves do actually reduce transmission of MRSA and VRE in hospitalised patients. So this survey was about laying the groundwork, I suppose, to explore whether there is the interest that we think there is in developing or designing an RCT that could be done in Australian hospitals to answer the question about efficacy as to whether gowns and gloves do reduce transmission.
That's an interesting point. And Josh, I'll bring you in here. There's been some literature in the past which has suggested perhaps that gloves and gowns for contact precautions for MRSA and VRE are not going to cause harm if they're withdrawn. What's been your sort of take on why we've got to this point? Why do you reckon these guidelines have changed when there's been some mounting evidence to this point?
Yeah, I mean, it's so established in practice and in people's minds that contact precautions means gowns and gloves in addition to single rooms and hand hygiene and so on, that I think it would be very difficult to convince people to have large-scale practice change without higher level evidence than what we already have. So, on a superficial level, what we already have might seem convincing, which is multiple observational studies all suggesting that it didn't really make a difference or it didn't cause a harm when people stopped using gowns and gloves. However, firstly, not all studies showed the same thing. Occasionally, smaller studies showed it got worse. And secondly, the literature is littered with observational studies of whatever intervention suggesting one thing and then a randomized trial showing the truth, which is the opposite to what the observational studies showed, because they're obviously subject to bias, subject to time effect and to confounding, etc. So I think randomized trials are really important. And something like this, it doesn't lend itself well to RCTs. It's not easy to do because it'd have to be, we'll talk about maybe in a minute, but it'd have to be a cluster level, etc. But to me, just because something's hard to do doesn't mean we shouldn't do it.
That's fantastic. And you're absolutely right about observational studies throwing up one thing. I've just actually finished a systematic review on a particular topic, and by and large, they were all observational studies, and they indicated a certain risk, but it actually contradicts what some of the RCTs would say on that topic. So it's fascinating. That's, of course, some of the bias we have with observational studies. So, Sarah, just going back to this study, and then we'll move on to some of those points that Josh alluded to. You decided to do a survey of those involved in infection control in Australia and New Zealand. Can you tell us a little about that?
Yeah, we did. So we designed the survey. I think there was 23 questions in our survey, which were designed to explore how people in Australian and New Zealand hospitals are currently approaching VRE and MRSA colonised and infected patients, because I guess we were coming at this question with quite a HNE, Hunter New England centric approach. And we needed to know what was already being done in other hospitals to know whether the idea of an RCT was actually feasible. So we asked people questions around whether they were using single rooms, whether they were using gowns and gloves routinely for MRSA and VRE. We also questioned participants around whether there was interest in removal of gowns and gloves for both VRE and MRSA in their hospitals, and whether they would be interested in participating in an RCT if one were to be designed.
So this was sent to members of the Australasian College for Infection Prevention Control and the Australasian Society for Infectious Diseases, and online, and you had a good response rate, I think, in all things considered.
Yeah, that's right. So we just asked people who work specifically in infection prevention and control. Particularly those who the survey was sent to through the Australasian Society of Infectious Diseases. Some of those people wouldn't have been eligible to actually participate in the study. So it's hard to sort of calculate a participation rate. But we had 220 individual responses for the survey, which were from 122 individual hospitals.
That's pretty good. That's a good response rate. In terms of the number of hospitals.
Yeah, I was quite happy with that. It's hard to know for sure, but I think we included all of the principal referral hospitals across Australia, and we also had 6 hospitals from New Zealand as well. So I was very happy with the participation.
And principal referral hospitals, for those international listeners, that's sort of the largest hospitals, if you like, in Australia. So that was good coverage of those. So what were some of the findings, Sarah?
So essentially, it's hard to report them all in the individual...
The headline ones, yeah.
Yeah. So look, essentially for MRSA, almost 86% of hospitals that were surveyed are currently using contact precautions, which we defined as use of a single room, gowns or aprons and gloves. And that was a little bit lower than VRE. So almost 92% of hospitals indicated that they're currently using contact precautions, including single rooms, gowns and gloves. We then surveyed people sort of individually looking at gown use, glove use, which was around the same for those as well.
There wasn't a lot of difference, was there?
No, not a great deal. But I think, what we could tell from those results is that the approach to MRSA and VRE, I mean, they were a little bit different. So I think more hospitals are tending to be, I guess, more relaxed with their approach to MRSA compared to VRE. And we can talk about the specifics of that in a minute, if you like.
And what about their interest in removing glove and or gown use for contact precautions as part of contact precautions?
Yeah, so it was quite high, but again, more interest in MRSA rather than VRE. So just over 73% of people who were responding on behalf of hospitals, so 73% of those 122 hospitals were interested in removing gown use for MRSA versus only 68% removing gown use for VRE. And that was fairly similar to interest in removing glove use. So that sat at 71% for MRSA and 70% for VRE.
And just slightly less interest in potentially participating in an RCT if that opportunity was to arise. I think it was about 60 odd percent.
Yes, 61.7%.
Yeah. So, Josh, I guess, what this is broadly telling us is, people are using gowns and gloves the majority of time for contact precautions or a combination of some of those. But there seems to be quite a bit of widespread interest to removing these gloves and gowns. And it's interesting that it hasn't happened yet. That we've seen, as you alluded to, we've seen these systematic reviews and other bits of observational studies suggesting no harm, but people haven't jumped on that bandwagon yet. But equally, 60 odd percent only wanted to participate in an RCT. So what do you make of that?
Yeah, I mean, I think it's important to note that 61% is not the number of people that have equipoise for the question. 61% is the number of of sites which would have capacity and time and interest to actually do all the extra work that it takes to be part of an RCT. So, the 40% that said, no, we don't want to be in an RCT, that doesn't necessarily mean they wouldn't be comfortable with the idea of removing gowns and gloves. It could mean that, but it could also mean that they don't have any research capacity at their sites to collect data and so on. And you're right, I think one really key thing here is, this debate. I've had this discussion with a lot of people that do we really need to do an RCT? There's a lot of evidence out there, but my answer is, well, practice hasn't changed, right? And if we want practice to change, we need to first find out, is it even true that gowns and gloves are of no added benefit? And we need to convince people of that fact. And the only way, I think, to truly convince them is to have a large-scale, well-designed trial. And, one thing that got me interested in this whole question is, when we had a lot of COVID patients in the ward, every time I'd go in and out of the ward, seeing that bin overflowing with plastic gowns and gloves just, made me sick. And, it was so visible, right? And you saw the bin being filled up and emptied before your eyes. And so just imagining how much landfill we're creating by that for something that we may not even need to be doing really needs addressing.
Yeah, that's right. So we've got the big environmental impact, of course, the cost of procuring all these pieces of equipment, and then there's the element of clinicians doing what they want to do, and if they're free of gloves and gowns, would that make other practices easier to do as well, particularly things like hand hygiene when someone's in contact precautions. So, and I would also should have disclosed I'm part of the discussions with this and an author on this paper too. But one of the things I think we've been discussing is, well, what type of design could answer this question? And you started to talk about that, Josh, at the start about a cluster RCT. What do you see as some of the solutions or options here for future design?
Yeah, so I mean, the sort of simplest RCT design is an individual patient RCT, but that really would not work here, right? Where you can't randomize every patient who comes in to either have gowns and gloves used in their room or not. That isn't practical. So the next level up would be a cluster RCT where you randomize entire hospitals, or sometimes in just wards of hospitals, to routinely do that practice or not do the practice. And then I guess the other. So that's one trial design, and the sort of the simplest and easiest to understand. The third one is a step wedge trial where every hospital participating gets the intervention. In this case, the intervention is removal of gowns and gloves, but it's introduced at a different time in each hospital, and that time is determined by randomization. And then finally, there's a crossover design you can use in cluster design, so that hospitals are randomized to either remove gowns and gloves now or do it in period number 2 a year later, and then the hospitals cross over. So there's different designs to consider. They all have pros and cons, and the power is different to each of them as well.
And speaking of power, that's the key thing here. I mean, what are people going to be interested in as the main outcome if we were to remove gloves and gowns for patients with VRE in our MRSA? I mean, what are people going to be most interested in saying, okay, we need to know about harm, but what harm are we interested in here? And what's acceptable?
I mean, I think it needs to be a patient-centered endpoint. So, and I think the one we've been considering is the number of new acquisitions of MRSA or VRE, and that would be combined clinical specimens. So, if there's a clinically driven specimen taken, a swab of a wound or a blood culture, as well as colonisation specimens. The reason to combine them, even though they're not the same thing, is otherwise you'd have insufficient power, I think, if you just made it clinical specimens. So we'd really want to convincingly show that the rate of new acquisition of those organisms was not any higher when we remove gowns and gloves. And that's where we get into the difficult area, because I think in the survey, we asked people what they thought would be a sort of clinically acceptable difference. And most people felt that anything above 5% would be too much. So if there was a more than 5% increase in MRSA acquisition, for example, then the intervention is not safe. The problem for powering it for that 5% degree of change needs a large number of clusters.
Yeah. And so what are your thoughts about sort of that outcome of acquisition How important is that, in your role of heading up infection control at Hunter New England? And how would you compare that to something like an infection with one of those particular organisms?
Well, I guess the problem is that one tends to lead to the other. And so I think from an IPC perspective, acquisitions are very important. It's just a difficult thing to measure unless you're performing routine surveillance on patients, and we just aren't doing that. So while I think acquisitions are still clinically important, it is important that we try to prevent transmission of these MROs in our healthcare settings. Pragmatically speaking, it's a difficult thing to reliably measure. And so instead we end up relying on, incidental findings of VRE in urines or wounds that happen to return a positive result for MRSA. So I think they're important, but I think when they're included in the context of a trial, we just need to be aware, I guess conscious of the fact that it may not be reliable or telling us the whole picture.
And of course, one of the big challenges of acquisition data is the screening practices that might happen or not happen and the variability associated with that. Just another complexity there. What do you see as the next steps for this piece of work?
I must admit, I feel a little bit conflicted, I think, and almost a little bit inspired too, to be honest, because what we found through this survey is that, somewhere between 10 and 15% of these hospitals have already abandoned contact precautions, in that traditional sort of format that we think of. And so I was really interested to read through all the comments and learn about what other hospitals have implemented. And, there were so many variations on these themes, including not instigating any contact precautions for non-multi-resistant MRSAs. Some people had different approaches for VNAs and VNBs. And I really enjoyed learning about the approach in the state of Victoria, where they use a risk assessment-based method to essentially determine the individual patient's risk of transmission. And I think, I think that's a really nice way of looking at this rather than applying blanket rules to every patient. And in a perfect world, we probably could abide by these blanket rules more easily, but in the real world, we have a shortage of single rooms, and that's been exacerbated by the COVID pandemic. So when we have these COVID waves, we rapidly run out of single rooms, and we're left needing to cohort patients with MROs. And, I think that with a risk-based approach, that could potentially be done in a safer way. And really, with my infection control hat on, what we're trying to do is reduce transmission events and keep patients safe. So I think, from a research perspective, this remains a really interesting question, and it does deserve to be answered. But from a practical clinician-based role, I sort of think, well, maybe we should be approaching contact precautions from a resource perspective and thinking about how can our healthcare resources best be used to protect the other patients in the hospital. And for me, that's really more thinking about how we use our single rooms and how we risk assess patients. And obviously we always come back to standard precautions and how important they are. So I guess that doesn't so much answer your question, but I think now that we have the results of this survey, we somewhat need to go back to the drawing board and think about where our resources are best placed to serve our hospitals and our patients.
Interesting thoughts there, Sarah. Thanks. And Josh, what about you? Any final thoughts from yourself about where to from here? And
yeah, I think I'm kind of on the other end of the spectrum from Sarah in that, my kind of cognitive bias is that I like RCTs, and I think there should be more of them in the world, and they're fun to do and important. But the other thing is, I'm going to just take one thing Sarah said and spin it on its head. In a perfect world, people would be able to individually and subtly risk assess every patient, and they would understand and follow these rules. But, my 20 odd years working in hospitals has told me a lot of people are bad at that, especially doctors and especially nurses who are not infection control practitioners or don't have access to one. So my feeling is that we need a simple kind of concrete blanket rule, even though it's not doesn't make the most logical sense. That's the thing that people will follow. And in order to create that, we need the RCT, like I said. But, we're going to continue to have this debate offline.
We will. We will. And look, it can also be a combination of those two things. An RCT that provides the headline evidence you need, but the ability to tailor based on individual context, epidemiology, and circumstance. And the risks and profiles of all these hospitals with the different approaches vary considerably across Australia and I'm sure across the world. So all those things to consider. Well, look, I look forward to continuing this conversation with you both and others in a larger working group that we're involved with to try and resolve this one way or other down the track. But thank you so much, Sarah, for your time and work on this, and Josh as well. I really appreciate it here on the podcast.
Thanks, Brett. Thanks for having us.
Thanks, Brett.
My pleasure. And that's a wrap for this issue of Infection Control Matters. Thanks, everybody.